tip-beyond roll is basically flying the maxillae. So the maxillae, all those sutures, I can take and influence them with the expander by putting the arms high and low on the arms, and then by having traction off the face mask. When the elastic is placed, that side's going to be drawing down, and we're going to change the occlusal plane as they wear it. So it's like we're flying, but we've got crosswind, so we're going to bank a little bit to keep on our trajectory. I can bend those arms up or down. That's my answer sheet. That's my flight plan. That's my target. That's my landing. With class 2 and class 3 types, the palatal plane is characteristic. I want to see people when they present show these kind of things, not just a picture before and after and say it looks great, and it does, but where did the change happen? Prove it. And then publish that, because the more you publish it, the more the airway benefits and traction will get in the journals and be the message. A teen, I'm not going to be able to do orthopedics on them. I'm going to relocate the dentitions. This is orthodontics. This is not orthopedics. As we expand, we get not only more perimeter to the arch, but we get more nasal airway so that it helps flow, helps turbulence. If we imagine 10 millimeters of expansion, that's 24% change in flow characteristics, which are measurable and certainly make a difference in breathing and sleep and all functions. We'd love to see there be a network of all people up and down every street doing these things, but they aren't. And we all struggle with trying to help the message get out there. The nasal maxillary complexes come forward, opening up the back region of the airway and making tongue space. The 7, 11-year-old, we don't get as much orthopedics. It's more 30% orthopedic, 70% dental alveolar. Still beneficial, but not the same as it would have been on a 3 to 6-year-old. But it is face forward, same principles where we have an expander and we're going slow. Face mask is being worn. Takes a few months longer at that age, but we still get real beneficial change. A helpful idea is on the expander to extend arms up around the 2 incisors and cross over the midline. So as the arms expand, it keeps the 2 center teeth more or less together. So you don't get the big raging diastema. It's just a design feature. It's better to optimize the kid's structure, function, behavior than to repair them later as adults. And yeah, we can do incredible things with double jaw surgeries, chins, hyoid, all the stuff we do. But right here, we can do a whole lot in a simpler way, and the kids respond so quick. What we do early is the most important for sure. And if it's an older patient, we can still overcome things, but later I can't do as much. I can add some kind of TADs in the palate, use the same arms, and do the same things, only to a lesser degree, because I don't have the orthopedic benefit. Molars in class 2s are always mesially rotated. Research on class 2 malocclusions, and 100% of the time, molars have mesial rotation on the upper. So they need to be derotated as part of our initial treatment steps. What happens when we derotate, we gain space in the arch. What about the malar process? Since we're relying on this region of the anatomy of the maxillae, the malar region matures real early. Around age 2 already, most of these sutures are already highly convoluted and they're very supportive. That bone isn't going to suddenly displace. There's too much that's holding it. Zygomaxillary sutures, they're resistive to remodeling and they're highly interdigitating. They're longest and thickest of the maxillary sutures, so they're not going to change with the protraction forces. After all this in mind, that gave me a basis to go ahead and design the one that we have. You would think, well, we can't put pressure on that because it's developing, except it's already developed as much as it's going to. On a 2-year-old, I'm not going to do that. If I had to put a mask on a 2-year-old, I'd go to the chin, because I'd rather be on the chin and not risk anything changing here until it's mature. But 3 to 4, I have no hesitation. I'm relying on cone beam. I wanted to communicate the low dosage that is occurring. It's certainly not a risk factor. The technology is so good. This stuff is way better with cone beam than we ever had. When that upper is really narrow and deficient, the lower has consequences, and certainly the tongue placement and airway are at a big disadvantage. We don't use the forehead for any kind of reference. We always want to relate the middle face and lower third because they function and look together. We're not trying to make anything match to the forehead because different parts of the world, the foreheads are different cranial shapes, different cranial vaults. I appreciate how much speech and swallow and myofunctional has to do with every success I have on a case. So why do we do all this? We want to give each kid the best possibilities in life, and it begins with airway and health and tongue function and all that. How do we deal with some of our colleagues who might push back on this or not even think it's relevant or important? The priority of a kid, I mean, none of what we are or do matters except in the life of those kids and where they'll be 50 and 100 years from now, the lifetime they can have because of something we're doing now. So many of these colleagues don't know what they don't know, but what they do know isn't enough. We want to get the air box working. If they snore, you got to do more. So we want to screen every patient as if they're an airway patient. We want to teach the colleagues that the snoring patient gets on this cascade. That's not good. So breathing problems are pathway to sleep disorders and more. All the other health and medical disorders. I'm going to keep carrying my message of airway and facial orthopedics with my colleagues. I'm going to reach the public. They're going to end up coming your way, and then you can collaborate. So jump on board. Try to be the best colleague you can be. Keep thinking, colleagues. Keep rising. Dare to soar. I'll see you at the top.